Okay, it's always hard to go after Dr. Damrow, so I'll try. Hello, and thank you for this opportunity to present today during Dysphagia Awareness Month. Thank you to Heather and the organizers for putting on this talk and bringing awareness to dysphagia. So I was asked to discuss tongue strength and dysphagia management. Oh, I can progress to the next one.
You're doing that and it's not working?
Yeah.
Yeah, just do this one.
Okay, I have nothing to disclose. My objectives for this talk are to give a very brief anatomy review of the tongue musculature, then discuss the role of the tongue in swallowing, factors that influence changes in tongue strength, exercise science and swallowing function, efficacy of tongue strengthening protocols and future trends. And I'm happy to answer any questions if there's time, and I will be on time. Okay, so let's start off with a quick review of the anatomy of the tongue musculature. The tongue is a skeletal muscular organ situated in the oral cavity. It's an accessory digestive organ. It's considered a muscular hydrostat in that it has a free end that is not attached to joints or tendons, which allows us to articulate sounds, chew, and manipulate food in preparation for swallowing. An elephant's trunk or an octopus's tentacles are also considered muscular hydrostats. The tongue is separated into two halves by a connective lingual septum. There are 4 pairs of intrinsic and extrinsic lingual muscles, which are shown in this image. All of the intrinsic and extrinsic muscles are innervated by the hypoglossal nerve, except for the palatal glossus, which has vagal nerve innervation. So the tongue muscles are considered skeletal muscles because they're under volitional control, and the 2 types of skeletal muscle fibers that I just wanted to briefly touch on are slow twitch type 1 and fast twitch type 2. So slow twitch muscle fibers support long distance endurance activities like marathon running, while fast twitch muscle fibers support quick, powerful movements such as sprinting or weightlifting. With respect to tongue muscle fiber makeup, the anterior 2/3 of the tongue region is composed predominantly of type 2 fast twitch muscle fibers, and these fibers have been shown to be proficient in performing movements used for strength, power, speed, where they can accommodate functions such as chewing during swallowing and articulatory movements during speech production. The posterior third of the tongue is comprised primarily of type 1 slow twitch muscle fibers, which are known for being relatively fatigue resistant. Sorry, I'm trying to. Okay. And are therefore well suited for functions such as maintaining an upper airway during respiration, closing off the upper airway during mastication to prevent premature spillage into the pharynx. So the tongue plays an important role in swallowing, specifically in forming a bolus, containing the bolus while chewing, oral transit time, propelling the bolus back into the pharynx for swallowing. So let's delve into some research first on normal variations of tongue strength and then changes to tongue strength post-disease processes resulting in dysphagia. And then I'd like you to think about the clinical relevance for your patient population with respect to tongue strength and your swallowing treatment recommendations. So let's begin with reviewing some data regarding variations in tongue strength with regards to gender, bolus viscosity, and even distinctions within the tongue muscular itself. So in a study by Gingrich in 2012, he looked at both anterior and posterior tongue pressures when swallowing saliva, thin, and honey-thick liquid. And he found that there were greater lingual forces in the front of the tongue for all consistencies presented, which makes sense as we were just talking about, that the anterior tongue is made up of those type 2 fast twitch muscle fibers, so it's proficient in performing movements used for strength, power, and speed tasks. His study also noticed increased tongue pressures when swallowing thicker viscosities. So Steele et al. In 2019 collected detailed information about how we change the amount of tongue pressures used when swallowing thin to moderately thick liquids. And similar to Gingrich's results, Steele also noted that there were increased tongue pressures with thicker consistencies. And her study, interestingly, also showed that there were no change when someone had thin and thick barium with thin and thick liquids with and without barium. So she was kind of one of the first studies to say what we do in the modified barium swallow suite actually translates clinically when we're making our recommendations after. Okay, so the tongue There can be tongue changes to strength with general aging as well as with disease processes. For example, humans in 2008 wanted to evaluate tongue strength in the aging population and noted significant differences in maximum tongue strength between the youngest participant group, who are about 20 to 39, and the oldest participant group, who are about 60 to 79, where the older group had reduced maximum tongue pressures compared to the younger group. Functional lingual reserve is something that has been researched over the years and is defined by Steele and others as the difference between your maximum tongue pressures and your normal saliva swallows. And initially it was hypothesized that lingual reserve reduces with general aging. However, both Steele and Humans noted that functional reserve does not diminish with normal aging. Humans did note, however, that there was a statistically significant difference with functional lingual reserve with gender, as females had a reduced lingual pressure reserves compared to males in his study. And changes to tongue strength with disease processes have been extensively reported in the literature. Just briefly, tongue strength changes or declines in patients after stroke, Parkinson's disease, head and neck cancer, motor neuron disease, just for example, and then with healthy aging. So we can have decreased tongue strength has been associated with bolus residue in the oral cavity and the oral pharynx, increased risk for aspiration, and all of these things can have side effects for or repercussions for general overall health. Okay. So there are some interesting articles regarding changes to tongue strength following meals. And so Kays back in 2010 completed a study examining the effects of eating a meal on tongue strength and endurance in healthy young folks, 20 to 35, and some older folks, 65 to 82. And the results revealed that all the subjects demonstrated reduced tongue strength and endurance post-meal, which consisted of a half a bagel with peanut butter, carrot sticks, and a glass of milk, given in 2 sessions. And the tongue measurements were taken before and after each session. It was interesting to note that the 3 oldest subject participants reported the highest effort in swallowing and actually showed signs of dysphagia while eating. So 7 years after Kay's study, Namasavaya and McDonald completed a study looking at the effects of an 8-week tongue strengthening program on mealtime function in elderly aged 84 to 99, long-term care patients with mild to moderately severe cognitive impairments. And the results revealed that the elderly people with cognitive impairments can participate in tongue strengthening exercise and show improvement in their tongue strength. However, this study did not reveal a statistically significant change in mealtime duration or food or liquid intake. And then just last year, Braitz and Mulfenter explored the effects of eating a meal on lingual pressures, endurance, and other swallowing function parameters in normal eating conditions when compared to an intentionally fatigued tongue in healthy young and older patients. And I thought this was a really interesting article. What they did was they had folks use a handheld manometer like an IOP bulb and fatigue their tongue. They had to do tongue presses until they couldn't reach 40% of their maximum. And then they had them eat something, and they used the same foods as case study. So it was really interesting, and they showed that older participants may be more vulnerable to fatigue-induced changes on tongue pressures. So let's shift to just a really brief discussion on neuroplasticity and review the current literature regarding correlation between tongue strength protocols and improving overall swallowing safety and efficiency. So neuroplasticity simply refers to the lifelong capacity of the brain to change and rewire itself in response to the stimulation of learning and experiences. There are chemical, structural, and functional changes that occur in the brain with exercise. So we can make neuroplastic changes to our tongue strength by completing progressive resistance exercise protocols using devices such as the Iowa Oral Performance Instrument or the tonguometer, which are both pictured on the screen here, and our handheld manometers that measure maximum tongue pressure in kilopascals. They also provide visual feedback to assist showing changes in function over time when performing tongue strengthening and endurance exercise protocols. So Burkhead Morgan in 2007, if you haven't read this article, you have to read it, it's great. They looked at strength training exercise and dysphagia rehab and discussed some data related specifically to tongue strengthening protocols. And they noted that isometric tongue strengthening exercises can improve swallowing function when using progressive resistance exercise protocols, like with the IOP. And future research really needs to focus on the appropriate volume of exercise by adjusting recommended treatment dosage. Zimmerman in 2020 completed a review article regarding the application of selective motor learning theories to feeding and swallowing across the lifespan. And they reported really encouraging research regarding behavioral treatment effects on swallowing functions, but noted more research on behavioral drivers that alter plasticity and promote swallow recovery is really highly needed. And their article discussed the idea of focusing on promoting motor recovery versus motor compensation. And they defined motor recovery as like movements will be performed in the same way it was performed before an injury. And conversely, motor compensation was defined as the appearance of new motor patterns emerging to adapt and replace the injured motor patterns. And Zimmerman also noted that we can enhance motor adaptation and swallowing efficiency by applying our knowledge of how muscles work, prescribing appropriate exercise dosage, frequency, variability of exercise and practice patterns using biofeedback tools like the IOP, and focus on systematic progression of skills. So in reviewing the literature on efficacy of tongue strengthening protocols, there were a number of systematic reviews and a recent scoping review that reported on the current state of research and future direction and recommendation. Now, overall, these research reviews reported gains in maximum tongue pressures following isometric tongue strengthening for both adults with and without dysphagia. And although they reported it's really a promising field of research, they just felt like the current literature is too variable with respect to the methodology and the patient populations, really to determine the efficacy of this treatment protocol. So specifically, Samawi in 2019 reported protocols in their review ranged from 4 to 12 weeks with number of repetitions anywhere from 30 to 90 and frequency of practice anywhere from 2 to 5 times per week. And Kreckler in 2021 reported that the duration of some studies were 4 weeks up to a year, and that there were highly varied outcome measures used with swallowing exercise protocols, including tongue strengthening protocols. So collectively, these studies discuss that future research should include RCTs with a homogeneous group of participants and have specific inclusion criteria such as frequency, duration, repetition, intensity of exercises recommended in order to really improve reproducibility, interpretation, and comparison across studies. And I just wanted to end with this promising new NIH-funded clinical trial looking specifically at what the optimal method for tongue strengthening is, as the researchers want to evaluate effectiveness of exercise intensity progression compared to standard practice in swallow rehab. Their plan is to develop a framework for guiding clinical practice of tongue strengthening in various dysphagic populations, and the results of this study may assist speech pathologists in making appropriate dosage for exercises for improving tongue strength for swallow function. And to conclude, there are normal variations to tongue strength with respect to age, gender, part of the tongue, as well as disease process, and even post-meal times that can affect overall swallow function. And participating in a progressive tongue strengthening treatment programs can result in improvements in both tongue strength and swallow function, and more robust research is needed to continue to advance this well-used treatment paradigm. Any questions and references? Timing? Okay.